This next relatively short lecture is going to focus on cardiorespiratory responses to exercise. So before we actually get into the responses, I do want to review a little bit on some cardiovascular variables that are going to be really important. So first of all, cardiac output. I'm sure you know what cardiac output is. If not, cardiac output, commonly abbreviated by Q, is the amount of blood pumped out of a ventricle each minute. Units are commonly in liters per minute, and that amount, the cardiac output, depends on two things. It's going to depend on the heart rate, which is basically the number of times the heart beats per minute, or more specifically, the number of cardiac cycles in a minute, and that's given in units of beats per minute. And then also the stroke volume. Stroke volume is the amount of blood pumped out of a ventricle each beat. The units are commonly in milliliters per beat. So the standard equation that you may have seen before is cardiac output is determined by heart rate times stroke volume. So I want to get into a little bit of cardiac output regulation, and this gets a little complex. So I want to start with stroke volume. Heart rate's relatively easy, so we can do that in a matter of seconds, but how stroke volume is regulated is really important. So there's three major factors that regulate stroke volume in the human body. One is called preload, one is called afterload, and the other is called inotropy, or more commonly just known as contractility. So we're going to start with preload. So preload by definition is the amount of stretch put on cardiac muscle cells before they contract. And if you think about it, what makes the cardiac muscle cells contract more is that the heart is filling up more. And that blood coming back to the heart in the venous circulation is commonly referred to as venous return. So the more venous return you have coming back to the heart, the more the heart fills up, thus the more stretch on the cardiac muscle cells, thus the more preload. So there's a law that describes the effect of preload on stroke volume, and it's called the Frank-Starling law. Sometimes it's called the Frank-Starling mechanism. But basically it says a greater preload leads to a greater stroke volume, at least up to a certain point. So this graph is commonly shown, and stroke volume is on the y-axis. We have left ventricular end diastolic volume on the x-axis, and I'll talk a little bit more about this volume in a moment. But this is basically how much blood is in the left ventricle at the end of the filling phase. So when the heart is completely full, like when it's completely filled up, the ventricles are full, that's the end diastolic volume. So the more filling leads to a greater end diastolic volume, thus a greater preload leads to a greater stroke volume. And you can see at some point you get a diminishing return, and you can't, so in other words, you can't stretch the fibers too much. It won't continue to increase the stroke volume forever. It's going to eventually plateau, and then it may actually start to drop if you stretch them too much. But most commonly we're working in this range right here. All right, so this is really important during aerobic exercise. So I want to talk about during aerobic exercise, what are some factors that influence this venous return and maintain venous return, and thus maintain the preload, which is going to maintain our stroke volume during exercise. So I have three things listed here, and I just want to touch briefly on each. So venoconstriction, which is constriction of the veins. So venoconstriction just refers to how veins, even though they don't have near as much smooth muscle as arteries do, they still have some smooth muscle, and they can constrict and cause kind of a pumping effect to pump blood back towards the heart. And that is going to aid in venous return during exercise. Something that is highly focused on aerobic exercise, especially where you get this rhythmic contraction of skeletal muscle, like running or walking or cycling, you get a skeletal muscle pump, and that's what this picture is showing. So it's showing during calf movement. So let's assume you're running or walking. Each time the calf muscles contract and relax, you get a pumping effect, and that is going to help pump blood back towards the heart, thus maintaining venous return and thus increasing preload and stroke volume. And then lastly, something we don't commonly think about, respiratory pump. So the respiratory pump refers to the rhythmic effect of breathing. And so how every time you inhale and exhale, the pressure changes in your thoracic area. So when you inspire, you can see the pleural pressure drops right here, and when you expire, it comes back up. So inhale, exhale. You see the pressure is constantly changing. It's going to keep doing that. That actually impacts venous return. So when that pressure drops due to you inhaling, venous return actually goes up, and vice versa for the expiratory effects. So you could imagine during exercise, your breathing depth is going to increase, and also the rate is going to increase, and that's going to facilitate these rhythmic changes and thus increased venous return also during aerobic exercise. All right, then the other two I'm going to spend less time on. Afterload, it just refers to the pressure that the heart has to push against. So if you envision the pressure in the aorta, so that's the pressure that the left ventricle has to overcome to eject blood. So that's the pressure that the left ventricle has to work against. So that is, in simplest sense, that's the afterload. So the higher that afterload, the harder it's going to be to pump blood out of the heart. So we commonly say that afterload has an inverse relationship to stroke volume, meaning the higher the afterload, the lower the stroke volume. And then contractility, sometimes called inotropy is the scientific name, but it basically means how hard the heart is contracting. So we'll just call it contractility for now. This is highly determined by catecholamines, which are released by the autonomic nervous system. Namely, your sympathetic nervous system is going to secrete norepinephrine. Also, it can stimulate the adrenal gland to secrete epinephrine. Those catecholamines have a major impact on contractility. They're going to increase the forcefulness of contraction. And during exercise, the sympathetic nervous system is active, highly active, and thus contractility is going to go up. And the more forceful contraction, the greater the stroke volume. So there's a positive or direct relationship between contractility and stroke volume. And then getting back to heart rate, the other part of cardiac output, relatively simple. The heart has an intrinsic rate set by the SA node, and then that can be altered by your autonomic nervous system and also hormones. So your sympathetic nervous system speeds up the heart rate, parasympathetic slows it down. Hormones, such as catecholamines, again, can increase the heart rate. And so the regulation of heart rate is relatively simple. So you have an intrinsic rate, and then autonomic nervous system and hormones can deviate it from that rate. Some other heart volumes before we actually get into the responses. This is where I wanted to come back to end diastolic volume. So left ventricular end diastolic volume, as we said earlier, is basically the volume of blood in the left ventricle at the end of diastole, meaning the relaxation phase of the heart. So when the heart is completely full, as you're seeing in this picture, that volume in your left ventricle, that would be the left ventricular end diastolic volume. The left ventricular end systolic volume is the volume at the end of systole, or at the end of the contraction phase. So you can see there's less because that blood's been ejected. And so the difference between those two basically is our stroke volume, because the difference between what was in there and what's left is how much came out, which is how much was ejected each beat, and that's our stroke volume that we were talking about. And then another volume for you, ejection fraction, is a percent. So percent of blood that's in the left ventricle that was ejected. We can calculate this by stroke volume divided by the left ventricular end diastolic volume. So in other words, if we had the stroke volume and divided it by what was initially in there, we're going to get a decimal point, and we just convert that to a percent. So normal ejection fraction at rest is usually around 60 to 70%. So about 60 to 70% of that end diastolic volume is coming out of the heart. All right, touching on pulmonary ventilation really quick. I'm just going to go over three variables. VE, of which I commonly just call pulmonary ventilation, or minute ventilation, it's commonly referred to also, is the volume of air exhaled per minute. So given in units of liters per minute. So VE, liters per minute exhaled. It's determined by the breathing rate, or breathing frequency, which is measured in breaths per minute, and the tidal volume, which is the amount of air that actually is exhaled per breath. And I put some average volumes in here just to give you an idea. So rest, breathing rate, around 15, maybe a little bit less. 12 to 15 is a good guess. Maximal exercise may go up to around 30 to 50. Tidal volume depends a lot on body size, but rest about half a liter, and maximal exercise can go up to 3 to 3.5 liters. So just looking at these numbers, we'd say a normal resting pulmonary ventilation would be about 7.5, just strictly using these numbers. So we could calculate it by breathing frequency times tidal volume. This is a very similar equation to the cardiac output, but now we're talking about breathing. All right, and then one last equation, Fick equation. This is a really important equation in exercise physiology. It's VO2 equals cardiac output times a VO2 difference. So we can rewrite that obviously as VO2 is equal to heart rate times stroke volume times a VO2 difference. So all of you by now are familiar with what cardiac output is and heart rate and stroke volume. If you don't remember what AVO2 difference is, I'll just elaborate really quickly. AVO2 difference stands for the arteriovenous oxygen difference. So it's basically the difference in oxygen content between the blood and systemic arteries and the blood and systemic veins. So if you can envision systemic arteries carrying blood with oxygen towards skeletal muscle, and then systemic veins carrying that blood away from skeletal muscle, the veins are going to have less oxygen than the arteries. And so that difference reflects how much oxygen was extracted by the tissues. And so we call that the AVO2 difference. So it's an indicator of how much oxygen is being extracted from the tissues. And as you could imagine, during exercise, this is going to go up. But that also is important for determining our overall oxygen consumption. All right, so on to the responses. So heart rate, the response to aerobic exercise, and just FYI, to make this as easy to interpret as possible, we're going to talk about what we call incremental exercises. Incremental exercise meaning exercise where the intensity is gradually getting harder and harder until someone reaches their maximal capacity. So heart rate, we see that in this graph here. There's a linear increase in heart rate with increasing intensity. So linear is a key word. Straight line heart rate, as intensity goes up, heart rate goes up. Resting values 60 to 80, maybe a little bit lower. In some individuals, those are all standard numbers that are acceptable. Max, the easiest way to predict max heart rate is 220 minus age. There are more accurate equations, but 220 minus age is still commonly used just because it's so simple and it's still relatively accurate. Stroke volume is a little bit more to say about stroke volume, but in most individuals, as you can see in this graph right here, it's going to go up as intensity goes up. And when you get to about 40 to 50% of your max, it's going to plateau. Now, interestingly enough, in some individuals, stroke volume actually keeps going up. A lot of textbooks don't tell you that, but it is true. In people who are well trained aerobically, stroke volume will actually continue to go up all the way to their maximal level. And so mechanisms for stroke volume going up include increased preload, like we talked about, reduced afterload because you get massive vasodilation throughout the body during aerobic exercise, and then also increased contractility of the heart. And then together, cardiac output, I put some values in here also, but cardiac output you can see in this graph. So cardiac output is dependent on heart rate and stroke volume. So if heart rate goes up and stroke volume plateaus in this case, you can see cardiac output is going to be somewhere in the middle. And you can see it'll peak out around 20 to 30 liters per minute, maybe even more in a well-trained person. Now, one thing I should point out about stroke volume also is there's a huge range here for the maximal values, and that's because in some people it continues to go up and other people's it plateaus. So you could imagine there's a wide range of maximal stroke volumes. All right, so other variables, systolic versus diastolic blood pressure. So systolic blood pressure is the blood pressure during the contraction phase of the heart. Diastolic during the relaxation phase of the heart. So during aerobic exercise, as intensity goes up, there's a linear increase in systolic blood pressure, whereas diastolic blood pressure should stay the same. And diastolic blood pressure doesn't go up as a result of all of that vasodilation that's occurring during aerobic exercise. So you get blood vessels really dilating to increase blood flow to active tissues. You can actually see that in this graph here. This is the graph of what we call total peripheral resistance, which some people call systemic resistance, but basically it's the resistance to blood flow in the blood vessels. So you can see during aerobic exercise it drops in a curvilinear fashion as intensity goes up. That is a result of massive vasodilation occurring during aerobic exercise in an effort to get blood to active skeletal muscle. So this resistance drops, and that's actually gonna kind of limit how much blood pressure goes up. Systolic blood pressure goes up so much that it continues to go up, but diastolic, since it's lower, is gonna actually stay the same. It actually might. Diastolic blood pressure may actually drop during aerobic exercise. That's not that uncommon for it to drop a little bit. Shouldn't drop a lot, but it might drop maybe up to like 5 or 6 millimeters mercury. That would not be uncommon. All right, other variables, AVO2 difference, which we talked about. So in this example, this is the difference right here. So it looks like at rest about 8, we'll call it a percent. So 8%. And you can see as intensity goes up, that percentage increases. So AVO2 difference goes up during exercise, as we said, which reflects that the muscles are extracting more oxygen. Blood volume, wanted to touch on that. So blood volume actually is going to go down acutely during aerobic exercise, and that is a result of what something called hemoconcentration, but we get a plasma volume shift. That's the big thing. So we assume this is the blood. This is a blood vessel here. You can see as blood, and we'll assume this is tissue right here. And this is the arterial side, this is the venous side. So as blood is pushing through here, it's under pressure, so some of that plasma is actually going to be pushed out. And then on the venous side, some of what was formerly plasma, which is now just interstitial fluid, comes back in. So you can see at rest it balances each other out. But during exercise, the pressure goes up so much that you get more plasma pushed out that then can actually come back in. And then as intensity goes up even more, you get even more plasma pushed out, and not as much can come back in. So during acute exercise, depending on the intensity, you actually do get a drop in blood volume, and that's strictly a drop in plasma volume due to this plasma volume shift. And we call it a hemoconcentration effect because it's making the blood cells in a greater concentration in the blood. And then lastly, on this slide at least, RPP is the rate pressure product. Rate pressure product is a variable that's calculated by heart rate times systolic blood pressure. And it's commonly used to give an index of how hard the heart is working. So heart rate times systolic blood pressure. It's also known as the double product. But just think rate pressure product of heart rate and systolic blood pressure. So the units technically are beats per minute times millimeters mercury, and because here it just says arbitrary units, but we know that heart rate goes up linearly, systolic blood pressure goes up linearly, so RPP is going to go way up during aerobic exercise, and the higher the intensity, the higher it's going to go up. So as far as blood flow redistribution, this is a pie chart showing blood distribution at rest, and this is maximal exercise. So there's a couple of key points I like to point out on this slide. And first is, at rest, we get this nice, pretty relatively even distribution of blood flow to different organs. So some going to muscle, kidneys, brain, heart, skin, liver. But look how all this changes as exercise intensity goes up. So if you compare rest to max, it's pretty dramatic, but you can see there's a huge increase in blood flow to active skeletal muscle. And this is a result of all that vasodilation that we get redirecting blood flow to active skeletal muscle. And at the same time, a couple of things I want to point out. If we look at an organ like the heart, blood flow actually goes up to the heart, which makes sense because the heart's working harder. So I'm going to look at the absolute units here. So at rest, we had about 200 milliliters. It goes up about 5 times. So about at very maximal exercise, about 1,000 milliliters. So blood flow to the heart goes up also, as you would imagine. Skin blood flow, in this case, it's going up 300 versus 600. And again, that's in an effort to cool off the body. So that cooling effect, so you need to redirect some blood flow to the skin. The brain, 700 versus 900. So it goes up a little bit, but not drastically. So a good way to describe how blood flow to the brain changes during exercise is that blood flow to the brain is maintained, because this is definitely an organ you don't want to reduce blood flow to. And then if you look at some of these other organs like the liver and the kidneys, even though they have a lot of blood flow at rest, it drops dramatically during exercise. And that's because these organs, although they're vital to the human body, during exercise, when your body's under that type of stress, you don't necessarily need an overwhelming amount of blood going there. And you can take some of that blood that was going there and redirect it to the tissues that really need it during exercise, like muscle, the heart, and the skin. All right, shifting gears a little bit here, I want to talk about just the cardiovascular response to resistance training. And so, assuming we're talking about dynamic resistance training where there's actually movement occurring, like you're doing a bench press exercise with repetitions. So the response is going to depend on the intensity, which is basically how much weight you're lifting, and also the number of repetitions. So higher intensity or heavier weight, greater the response. More repetitions, greater the response. So if we look at a variable like heart rate, it's going to go up. More repetitions, greater intensity, it's going to go up more. Stroke volume, this is a big difference from what we saw with aerobic. Stroke volume is actually going to stay the same or drop. The reason is that stroke volume stays the same or drop. You don't get that big increase in preload that we got during aerobic exercise. You lose it. So pressure during resistance training, you get a lot of pressure built up in the thoracic area. That's going to compress the vena cava and all these veins bringing blood back towards the heart. That's going to limit venous return. Thus, you're going to lose the preload that we saw during aerobic activity, and stroke volume's not going to go up. Cardiac output will go up solely in response to that increase in heart rate. All right. And then lastly, systolic and diastolic blood pressure, another difference here. I graphed this out because there was a research study that showed data similar to this. So if you were doing an exercise, I think the data I got this from was based on leg press. So number of repetitions of the leg press exercise, you can see both systolic and diastolic blood pressure go up. The more repetitions you do, the greater it goes up. And also you can see within repetitions, the different phases that goes up. So during the concentric versus the eccentric phase of the exercise, blood pressure is constantly going up and down a little bit, but overall over the course of a set of repetitions, it's going to keep going up. Same for diastolic. This is a big difference from aerobic also, because remember aerobic exercise, diastolic blood pressure stayed the same because you got a lot of vasodilation. Well, the difference here is that during resistance training, you don't get all that vasodilation. You get some, but not near as much. So that the vasodilation can't offset that increase in blood pressure, and thus diastolic blood pressure is going to go up also. So key point, both systolic and diastolic blood pressure go up during resistance training exercise, and it's dependent on not only the intensity but also the number of repetitions. So this could have implications for exercise prescription. Even though if you look at maybe clinical populations, older adults, they do recommend maybe up to 15 repetitions with a lighter weight. But more than that, is you can see the potential problem here. Blood pressure is just going to keep going up and up and up, and that could be a potential problem. So it's something to be aware of. All right, as far as ventilation goes, some of the ventilatory measures, I really just wanted to focus on one big thing here. So this is incremental exercise looking at pulmonary ventilation. And pulmonary ventilation, as exercise intensity goes up, aerobic exercise intensity, it doesn't go up completely linear. I'm going to use this graph right here because it's a little more clear. It goes up kind of linearly, and then there's a break point where it shoots up. This point is called the ventilatory threshold. And so pulmonary ventilation will go up during aerobic exercise as intensity goes up, and then it hits a point, ventilatory threshold, where then it goes up exponentially. And there's several reasons this could occur, but there is a primary reason that is believed to result in this ventilatory threshold, and it has to do with pH. So you can see about that same point where you're getting that increase in ventilation, you're getting a drop in pH. And this is back to basic physiology. You have chemoreceptors that respond to several substances, oxygen, CO2, or I should say PCO2, PO2, the partial pressure of those gases, and then also pH, or hydrogen ions. So at this point, at a given point, you kind of aren't able to buffer the acidity occurring in the body, so pH starts to drop, and then as a result, those chemoreceptors, which sense that, are going to stimulate an increase in ventilation. So pH has a pretty significant effect on this at determining this ventilatory threshold. Now, as you can imagine, the more in shape you are, this ventilatory threshold is going to shift more to a higher intensity. And that's due to several reasons. One is less of a stress on the body, and then also your body's better able to handle those pH changes. So you have a better capacity to buffer those hydrogen ions.